So just firstly, while that loads up, just to say a massive thank you for allowing me into this space. Kind of just while as people join, if you just pop in the chat who you are, where you're from, just really to get a bit of an idea who's here, because I know it's a mixed audience in terms of local authority, CCGs, NHS providers. Got a really good mixture. Oh, Glasgow, oh, we're coming even greater than Manchester, so that's great. Thank you. Have we got the slide deck up there? Yep, perfect. So if we move to the next slide, and just do add comments as you go into the comments box, and I'll try and bring them into the presentation. So as you can see, my name's Donna McLaughlin, so I work for the Northern Care Alliance, which covers Bury, Rochdale, Oldham, Salford. So think Bros if you get stuck in terms of think about where we're based. If we move on to the next slide, I've put the aims and objectives outlined in the slide deck. As we go on, I want to talk through the prepared presentation. I come from an ops background, so I'm much better at doing than I am writing and doing strategies. So this really is to think about the how, and really using this meeting to think about how we can do that within the kind of HR people community, and how we can kind of use each other as peer support to energize and to achieve. So the next slide just goes through the context of anchor institutions. So the last paragraph of the NHS long-term plan challenged the NHS to embrace the concept of an anchor institution. And in the information that went out, I think you saw a definition of anchor institutions, which is one that alongside its main function plays a significant and recognised role in locality by making a strategic contribution to the local economy. So it developed in the 60s in America and was further developed through collaboration through there. And it's kind of, in my mind, it's got three main characteristics. So the first one is anchor to place. So there's organisations that tend to have strong ties to the geographical area, and that may be through their capital, so a big building, their purpose, and the relationship between employees and citizens. Size, they tend to be large with significant purchasing power, so a shift in purchasing power or employment opportunities will therefore have an impact on the local communities. The third characteristics, they tend not to be profit, so there's less likely to move, and there's more of a guarantee that they'll stay within the local community for the long term. And I think for me, I can't think of a better definition of a NHS organisation, local authority or care provider, if we just add in the bullet points and provide care. So the NHS long-term plan, so that final paragraph, which challenged us to think about our power through those lenses, was further developed by the Health Foundation. So this in the slide, that's the picture that the Health Foundation used to describe the anchor institution as a specific definition for the NHS. They've more recently updated that with their account, taking into account the last 2 years, called Anchors in the Storm. So I guess I'm in a virtual room full of people professionals, and you don't need me to tell you that we have lived through an incredible and challenging period of our collective history. So pre-pandemic, there was existing racial and social economic inequalities, which have really been amplified by the pandemic and also the economic consequences of that. So structural inequalities drive poverty, which is one of the major contributing factors to poor health. And so like the virus, the economic and social consequences of how are having a disproportionate impact. So for me, how health systems, and I use the term health system to include social care partners, use and invest their resources are an important part of the resulting economic and social human benefit. So by thinking about how we use our resources and assets within local communities, and if we do take a responsible approach to employment, job creation, and the production of goods and services, health services can transform local communities so that they work for everybody, not the few. So what I tried to show in this central diagram is, what if we were to trap our human, social, and economic power specifically into those communities from focusing on those who are disproportionately disadvantaged, And that what I'm trying to show in this is that we need to funnel that NHS pound into our communities and to enable them to thrive, rather than perhaps assuming the trickle-down economics by putting money in, it's automatically going to land into those more deprived communities. So if I take the devolutions across Greater Manchester, there's brought fantastic new investment into the city. And certainly Greater Manchester, the city of Manchester, looks really different to perhaps what I remember 20 odd years ago. But we know that less than 7% of that has landed in Oldham and in terms of the outer skirts of Greater Manchester. And so really by thinking about how do we capture the public sector money into place, as well as the external stimulus that we may get from big developments such as what we've seen in the city centre. I've included a reference here to the Levelling Up white paper. I think it's going to be really interesting to see the influence of this policy direction and really to think about how the NHS is included in that debate for our economic and social power, not just in terms of as a provider of care. And the final component of this slide really balances with CLES. So CLES are actually a Manchester-based organisation, and for probably a good decade they've been championing something called community wealth building, which really challenges the ownership of that wealth. And I guess within a HR people context, it's about how employment supports healthier life and the whole that it's the decent work agenda, and it perhaps might be something we might want to explore later with thoughts on developments such as the GM Good Employment Charter and the whole living wage accreditation debate. If I was better at IT, I'd probably have a fancy way that I could then add in the NHS People Plan. And really in this space, I draw on the two themes of belonging, the theme 2 and the theme 3 in terms of growing your own. So if you just jump to the next slide and think about those two themes of belonging and growing your own, and really to ask, in our organisations, how rooted are we to our community? How do we think about belonging and growing, perhaps beyond our institutional walls? So to perhaps put that a different way by thinking through these questions. So we know that particularly during the pandemic, the support we had from the public in terms of the collapse on the doorstep, if we think about the volunteer support that we get, not just during the pandemic, but every day, the support we've had around vaccination centres. And so I guess for me, this agenda also speaks to the whole place-based leadership and systems thinking, and something about how do we step up and do more than just the brilliant work we do for care of the sick. So research shows that about healthy lives are driven, and I know there's some public health colleagues on this call, are driven at most 10 to 15% by health intervention. So that includes the timeliness and quality of services, but 40 to 60% by social economic factors, such as having a job, having a home, education attainments, a sense of purpose. So I guess for me, this anchor institution work really needs to matter to us as NHS practitioners. If we were to take off our hat of services and just think about our collective economic and social power at your disposal. So for the NCA, that's 18,500 people and £1.2 billion. So if we were to shift a little bit of that through the funnel that I showed in that previous slide and think about our approach to anchor institutional social value. So if we flip to the next slide, what we've done within the Northern Care Alliance is we took all of our concepts that I showed in the earlier slides, and in January 2019, the board approved what we've called our anchor mission. You'll find I tend to use the word social value and anchor institution interchangeably, and that's largely because I really don't like the word institution. I kind of feel I've spent 20 odd years trying to move health services away from being seen as an institution. That's just a personal view. Within the policy documents, it does tend to use the phrase anchor institution. So for the NCA, our mission is the use of our assets and influence in a purposeful and intentional way to ensure a sustainable planet, support the reduction of poverty through employment and job opportunities, including job and wealth creation by focusing on our procurement practices in place. So today it's within this third pillar of people that I'm going to focus on. So within the NCA, we talk about our anchor mission, and it's akin to a social movement. It's got clear ambitions, but we do need to walk humbly, recognising that the NHS is pretty late to this party, with other organisations, particularly in the voluntary sector or our local authority colleagues, have been doing this for a generation. So if you flip to the next slide, I've just described our people mission. So it's highly ambitious. So we'd call this in QI terms a big, hairy, audacious goals. But let's just rewind a bit and think about how do we get to these ambitions. So I've put at the bottom a kind of equation that I often had in my head when working through this programme, which is narrative plus data plus action equal change. So in the beginning, I talked through the narrative of what it means to be an anchor institution. And so I guess for people, the narrative is around that positive link between decent work and good health. And I guess our challenge is to really change that narrative around our workforce. So I guess what we're saying is we're changing the narrative from we want the best person for the job to how we're using our power as an employer to really tackle the social determinants of health and create a more just society. So the first thing I looked at was our data. And most big organisations, we've got loads of data, but probably not that much intelligence on the back of it. So I looked at all of our employees in terms of where they lived against salary, against postcode, and mapped it by deprivation. I reviewed our work experience, our pre-employment, our apprenticeships by protected characteristics. And there was really interesting patterns when we started to look at that. And also really importantly, we listened, and because for me, stories are data with soul. So the first paper that I brought to the NCA board in January 2019, I was accompanied by a young man called Patrick, who I had found by accident when I was up at the Rochdale site, who had come through a supported internship route with Elm Bank School and Pure Innovation. So I was at that point when you've written a board paper where you'd got comments from colleagues, and you get to that point, particularly if you're old like me and you're not very good at IT, that I'd gone to the photocopier and printed off four or five different versions of the document that I had. And Patrick spotted me and said, "What are you doing?" And I explained what I was trying to do, and he went to the computer and literally within 30 seconds merged all these documents and highlighted where everyone's comments were, and probably saved me about 3 hours worth of work. So we got talking, and I said to Patrick, "Will you come to the board with me, because I think your experience is going to say more than these words on these papers." And so what he told the board, he said, "I'm smart, but I have Asperger's syndrome, which means it takes me longer to get something, particularly in a social situation. But if you spend time with me, I promise I will repay you. And I'm very good with IT and systems and very, very loyal. Because after all, we were human. We're all human." But yet the UK Autistic Society found that 17% of their members were in full-time work, despite 77% of those not in work wanting to be and actively seeking. So just think about what other talent is out there if we tapped into it differently. So I was fortunate to be raised in a really large Irish family with strong women. And my granny used to say that the good Lord gives you 2 eyes, 2 ears and 1 mouth for a reason, because you should listen and observe twice as much as you speak. And so one of the first things we did was commission a voluntary sector organisation to go out and ask how we were perceived as an employer. And it really didn't make great reading, particularly from communities that ironically were really close, were our neighbours, particularly around where one of our main sites was. Also spoke to our further education principals, and perhaps it might be an interesting thought to pose to colleagues. Can they name the dean of the medical school? When did you last have a conversation? But what about the name of your further education institutions? What is the nature of that dialogue, given that a significant proportion of the NHS workforce could come from these routes? So back to the equation of narrative plus data plus action equals change. Well, action is always the tricky bit, what to do. And I think the first thing to say is we're all doing work in this space. What my challenge is to make it purposeful and structural, as opposed to necessarily a one-off piece of work or one-off programme. Because our anchor mission is the purposeful use of our power to reduce poverty, a structural response to the structural problem of inequality. So just flip to the next slide, and conscious that I just borrowed this from the internet, and there'll be colleagues, public health colleagues on this call who will be have more expertise than I in this space, but thinking about what this diagram says to me. So inequalities, unequal access to resource and power, which in this is apples on that tree. Equality is we distribute those apples more evenly, but still give everyone the same. Moving round in terms of thinking about how you support in terms of access to that power. But then for me, the final one is around justice, which kind of builds upon the previous pictures, but fundamentally changes the condition by not only thinking about the ladders, but thinking about the trunk of the tree, and probably also something about the soil that's underneath it. So by mapping our existing activities that we were doing against this framework really helps us challenge ourselves against our narrative that we're using our power as an employer to tackle social determinants of health and create a just society. So equal opportunity approach to recruitment is you give the job to the person who meets the job description following advertisement and interview. And inclusion perhaps means that you recognise that individuals require additional support. So people like Patrick, who came through one of our programmes. But as social justice responses, we change the system. So in 2019, we had 750 vacancies each year at band 2 to 5, which don't require professional qualification. So the 1,000 pre-employment learners came from that if we roughly estimate that between 75 and 85% of pre-employment learners will end up in a paid role, means that by 2025, we won't be advertising these roles as we currently do, but we will have created a pipeline of learners who have come from those place-based pre-employment learning opportunities. So we'll have recruited them against our NCA values. They'll already be employment checked and inducted and already have their mandatory training compliance, because surely turning up every day for a 12-week work-based learning whilst on benefits is a better judge of job readiness than a 20 minutes interview. And it also gives our managers that tangible thing that we put in job descriptions that says 5 GCSEs or equivalent, perhaps for that young person or carer whose education was interrupted, that they don't have, that it is more tangible. So so that, again, that's what I mean in terms of it's a structural response to a structural problem. By looking at our data in terms of our workforce data, we then are using that in order to inform where we then go in terms of to look at specific communities, either geography or through protected characteristics that we could outreach into. So this agenda really plays to our EDI. But we also have taken this back even further to career aspirations. So working through the GM Hub, we've really encouraged our staff to become NHS career ambassadors, but really think about where do we support. So we have spent a lot of time with our FE colleges redesigning the T-level curriculum and purposely using our FE colleges perhaps in some of our sixth form, because we know which are our FE colleges that feed from our lower income communities, so that we are giving access to work placements, perhaps those students who don't have the means within their family networks to connect themselves. So we were fortunate through the GMCA to get some funding to look at barriers to apprenticeships, and we took again a place-based approach to this. So we worked with one electoral ward to really see what assets and skills were out there, and we completely flipped the concept of recruitment on its head. So we took some predominantly members of the Bangladeshi and Pakistani community, and we used them to understand what the skills and assets they had. We then placed them into work trials that were unique based on their skills, rather than going into the community to say we've got 6 porters jobs, we've got 3 healthcare support workers. We flipped it the other way. We'd only got halfway through that programme when the local mosque contacted me to say, we really like what you're doing, can we pay for you to do a second one? So although we hadn't even got the statistics and how many people were working into work, we started to make inroads into communities. And the next programme that we actually ran it from the mosque, which is, it's less than about a quarter of a mile from the hospital, but doing it in the community made a difference. Julie's on the call, and we're just finishing a piece of work that we got funded through support through the ICS health care support workers, where we've actually taken that next stage further, that we've gone into community organisations to say, what are the barriers to employment? We've done a few different pilots around holding recruitment events completely differently by working alongside community groups. So if you flip to the next slide, so what has that all given us? So if we take narrative plus data plus action equals change. So for the last calendar year, we created 420 pre-employment opportunities. We've changed our internal recruitment processes so that we now have a job ready list, which is where all our pre-employment learners end up, and we then do almost like a organisational change approach, that then it's a chemistry check, interview, and straight into a role. We've smashed our target. We wanted to get to 50% of the NCA to be local. We're now at 57% from the baseline of July. Obviously, there's been some changes in terms of service configuration during that time. So I'd say about half that is to do with these interventions, and then half is because we also took on some more community services that by the nature have more local people. We've also doubled our NHS career ambassadors and work experience, and that's despite a pandemic, and that wasn't through a lot of hard sell. One of the things that we were getting feedback, particularly from the events that we've just run over the last 6 weeks by going into communities, is staff are really welcoming the opportunity to talk about what they do and to reinvigorate why they love the job that they do, because there's nothing more liberating than going and talking to a group of young people about why you made the career choice to do what you do. And so one of the findings we're finding from this latest piece of work is that actually it's really supporting staff wellbeing to just take a few hours to away from the really busy operational roles and just reflect on, this is why I wanted to be a nurse, or this is why I went into healthcare science, which is perhaps something that we didn't anticipate. So we track the performance through a dashboard, which goes to our assurance committees, including people committee, and ultimately to board. So whilst I do talk about this as a social movement, we do have measures. We bring each other to account, because I am an ex-director of ops, and so once a director of ops, I still do like a good trajectory. So we just flip to the next slide. This is an illustration of the kind of partners we've been working with, and I couldn't fit them all onto one slide. So I think we haven't done, we've done some programs which are NCA wide, like Kickstart. We've got a supported internship program of each locality, whereas others are really focused on one locality. So we're just completing a piece of work in Salford around domiciliary care. And as I've spoken about, the programme in Oldham, which was down to one electoral ward in terms of Coldhurst or Limeside, and we've done one specifically with a housing provider. So if we flip to the next slide, so the underlying methodology of how we bring this together is that twice a year we pull or staff across our care organisations with community partners, voluntary sector, and that's how we challenge ourselves to as to where to go next and how to set our mission. And we tried through those community practice to really use the voice of lived experience, both in the design and through the presentation. So if I just jump to the next slide. So whilst we are really still learning, I guess what I would offer in terms of kind of essential ingredients or learning, I guess I'm just conscious of time because I would really like to have a discussion. I think the first one is really to have a clear purpose. So what is the community we're working with? Is it young people? Is it members of the Bangladeshi Pakistani community? Is it T-levels? It's not just employability for employability's sake. Pastoral care is really key, and working with voluntary sector organisations has really helped. So for our youth programme, we work with Positive Steps. It isn't barrier to employment isn't just about employability skills. It is confidence building. It's support around moving off benefits. It's support getting to work. We've had young people who we've had to do practices on how to get on the bus. We use our NHS career ambassadors as mentors, particularly for things like the Kickstart programme. We do a mixture of talk components and employability, so hand-on work exposure. And we find that once we've found learners have found their tribe, so they found a ward manager or supervisor to nurture them, then the job's done then, because actually that team then carry that individual. Flexibility, it's always difficult because funders give you usually they want a positive outcome within 3 months, and if I be honest, we've kind of used COVID as a bit of an excuse to say it's taken us longer than 3 months, and that's really helped. because we need to take a strength-based approach, not a vacancy problem. So we often offer personalised work placements, and we may move people from a work placement into a volunteering opportunity that then moves on to paid work. Because for some people that step into work, it's not just a switch that you can switch on. I guess trust is a really, really big issue. So in order to really deeply penetrate our underrepresented communities, we need to recognise that as a public sector organisation, sometimes our name isn't the trusted name. So actually using housing associations, mosques are more trusted than us. I guess this isn't a separate project. It's linked to annual planning objectives. And I guess particularly for the HR community, DBS, you cannot start a DBS too early. We are losing excellent candidates because this takes too long. So in no way am I saying don't do a DBS. I'm just saying if you can, start at the beginning of a pre-employment programme rather than wait to the point at which you're at an interview. I'll take for an example a woman who we are now in month 7 of getting her DBS. So she fled the Taliban last time round. So she was a senior lawyer, was actually on one of their wanted lists because of being a female in a position of power. So she spent 2 years in an asylum centre in Europe and had to change her name for security reasons to get out of Afghanistan, and then changed her name again in Europe because it was again on security advice. She then came to this country and was advised to change her name again, and for that for children. She's in private rental, so she's moved around a lot. Her third name is an unusual name and has been misspelt on her utility bills. And also she explained where she's come from. You don't argue with official paperwork, so you keep your head down. So what we're finding is that actually it's those it's having the documentation is pretty key. I am really worried that from Friday, when 1st of April is, the benefit system is changing, that if you're not in a job within 4 weeks of a job offer, you could be sanctioned from a benefits point of view. And we know that it takes us sometimes longer to land that. So I guess if there's one big piece of advice is DBS them early. If we flip onto the next slide, I shared this with Nikki Clark and Estelle within the NCA. And what they said, maybe just do a little bit more on details. So what I've done is taken the Q3, so this just gives you an idea of the kind of programs that we put in. Kickstart, so Kickstart ends tomorrow. It's a national program. We've taken 6 to 9, hopefully 70 if we get another young person over the line the next 48 hours. That was government funded for 25 hours minimum hours, but we actually upgraded it to a band 2. We've got 90% of our first 2 cohorts into sustainable work, and we're looking at similar numbers for our last 3 cohorts. Like many of you within our NHSP contract, we've got the care support workers. It's in the policy and in the contract, and we police it. The GMCA was initially funded by GMCA for pre-apprenticeships, which really looked at takes 70 young people, moving down to 40 who would finish a taught component, 40 going to 10. We actually ended up with twice as many of those having a positive outcome, which was brilliant. We've now got that funded again to scale it up from the Princess Trust. This is really small cohorts, purposely designed work experience. But you don't get your outcome within 3 months, which is what the funders required. So we're having to do a bit of negotiation on that. The step into programs, the ones I've already talked about. So it's a 6-week taught day, 10 days over 6 weeks. And again, 30% moving into work, which is pretty much what we anticipate from those kind of things. But if I could have taken you somewhere, I'd take you to the day in Oldham when 42 of these people came in. So we do a talk component and then we do a matching interview for placements. And because of COVID, we'd had to hold back a number of cohorts. So we ended up with quite a large number for interviewing for the placements. And our expectation was that we would lose half at this point, that we'd find that when they got into conversations around jobs, we didn't match it. And what we found actually was that those 42, every single one of them we found a placement for. We had senior nursing doing the interviews, and they all filled in a value-based template. And I went in afterwards to say, so which are the ones that you can't accommodate, and I might have to go to other wards. And they'd sorted it. They had text their mates. They'd spoken. They may be a sister in charge of a medical ward, but the person expressed an interest in working with children. So they texted the paediatric ward, and in terms of it was just such a buzz. And in terms of to bring in a completely different cohort of people into the organisation. T-levels, so we've supported 60 odd T-levels. We actually then in the previous quarter, and we just found a digital cadet who slipped into Q3. In terms of other historic programmes that aren't on here that we use is the Growth Company, which also supports care certificates. So we're actually a subcontractor to the Growth Company for delivering that. So other schemes that aren't on here that we do twice a year, sector-based work academy with an FE partners. We've got the Princess Trust Get Into programme, which is a brilliant result. Again, about 80% of young people end up in paid work. And we've got a supported internship programme who run on each of our sites now, with 60 young people with additional learning needs that we support every year. And that's been running for 10 years at Salford Royal. So that is a really solid programme. So I guess data is only one of the part of the picture. So I know these slides are going to go out. So if we just flip to the next slide. So I would always say data is stories of data with soul. This is a link to our microsite that describe all of our programs. And so if we just flip through a few stories, I'll just pull some lessons from this. So these are two young people who came from our programme with the Positive Steps. And I think this young woman who's hidden behind her computer, I remember meeting her, and when she said she was anxious, she was physically shaking, and it had taken 3 goes to persuade her to get in the car and to come to the hospital. She hadn't left the house really for about a year. She now is on the vaccination, running vaccination clinics. She's doing an apprenticeship, and has just, you can just see, you know, the advantage of having three jabs is I've seen this young woman go from the person who was behind the desk to now, last time I saw her, there was a queue, as well quite often are at the vaccination centres. It was predominantly full of NHS staff. And at the end, there was an elderly gentleman on 2 sticks, and the rest of us hadn't noticed. And she came out and took this gentleman and brought him to the front of the queue, and turned around and looked at us all and said, he's old enough to be my granddad. And I felt ashamed that I hadn't noticed that. And it took someone who's only just starting her NHS career to remember the values that we live by. If we flip to the next one, this is from a parent. In terms of really knew what her daughter needed, found that actually she really struggled both in the education system and actually to work in a cohort of 10 and to have support of both a NHS and a youth work really worked, and that was just delighted to receive that. So she's now full-time employed by us. Flip to the next one. This is a young woman who was a main carer for a dad, and again, big issues around confidence, is working in health records. If you flip on to the next one, this is a young guy who had a degree. He's 30. He was in work, but it was insecure work. He actually had a biomedical degree. And he was 30, so he was on the upper age limit of the Princess Trust programme. And if we flip over, there's a nice picture of him, and he's now appointed to work in the labs. So he's actually taking his degree skills now finally to work into the NHS. The next slide is if you do get a chance to watch this, this is one of our young internship programmes. He's actually was a North Manchester colleague. Just seeing his delight of being able to work and the skills that he brings to us is just lovely to see. We flip on to the next one. So really, I guess I've kind of gone blur at you all. It's where to start, and I guess the first thing is to really think about what is your narrative, what is your pitch, how can you use the theory of anchor institutions, and how will that play out within workforces within that. Just look at your data. We've got loads and loads of data, both stories, case studies, rich data around workforce. What does that tell you? That will kind of give you pointers as to where to go next. Where does what you currently do fit within that continuum of the cartoon that are shown? Kind of what are the changes that you want to make? So do you want to link it into your EDI agenda? Do you want to link it into your hard to recruit areas? Or do you just want to link it in terms of this is where you want to add value in terms of your place-based leadership? And I guess most of this work, to be honest, have been done remotely in my head in this room. And what I've really found helpful is to have a couple of colleagues who you can support and support each other, because it can be a bit lonely doing this work, because you sometimes do feel all you're finding are barriers and ways to overcome them. So really, as a community, what support can you take from each other? And the final slides. There's some references to some of the reports that I talked about, and then finally just my contact details if anyone wants to have any further questions. And it's now over to discussions. Who's going to be brave? Should we take the slide up and down so I can see some people? Any questions? Karen, do you want to come in? Nice to see you again. I'm sorry I've stolen Jason, who's technically yours still, but you know, I love him.
Didn't know. I'll have to find out about that. So I guess for other people, Donna and I met 3 years ago at a social value conference, and Manchester Health and Care Commissioning has taken a really similar approach to the one that Donna's outlined in terms of using all of our social value levers to address inequalities within our workforce, but being mindful that actually it's about going above and beyond the Equality Act. This is not about making, having diverse recruitment panels, for example. It's something a bit more than that and quite separate. I suppose I just wanted to touch on living wage accreditation, because that's something that we did and it was really painful. But also around the time, well, it was just before COVID that we had taken a paper to our Health and Wellbeing Board around this, because Don, you made that reference to, say, the lack of trickle down or impact on outlying areas in Greater Manchester of all the economic growth in Manchester, but you wouldn't expect me to say anything other than the fact that actually in Manchester still we have people who are within walking distance of some of the anchor institutions who aren't in employment. We've still got so if you look at the wages earned by people working in Manchester, the average is higher than people who live in Manchester, wherever they work. So we've still got some massive issues that we see social value anchor institution work as being part of. And the single biggest thing that we could do as a city is all meet the real living wage, and that we'd only have NHS Band 2 roles for people in apprenticeships where there's a progression route. So just wanted to take some views on that, really, and just think about, because obviously then having local employment also has an environmental benefit as well. So there's also, I could talk for hours as well, but I don't want to dominate. So Donna, it'd be great to catch up with you about some conversations I'm having about measurement as well, and within the new integrated care system.
Yeah, that'd be great. There's a few hands up, so if we just introduce colleagues, and then we can see where the discussion goes. So Susan, I think you're next, and then Lisa.
Yeah, hi, Sue from the partnership. So Donna and I are sort of linking in with some of the work that she's doing around healthcare support workers. But I guess what I was thinking of, Donna, just to probe your brain really and get a sense of what is it, where would you like to take this going forward? What can you see in the short to medium term? And then actually, that might be, bearing in mind that obviously that might be in your own organisation, wider organisation. So the second question would be, you know, if other organisations were to pick some of this activity up, some of the good learning that you've demonstrated works really well from an NCA perspective, what do you see as some of the key challenges or barriers in order to sort of spread in some of that activity?
I think the point we're at is, I think we need to fundamentally restructure how we recruit. So going out and talking to communities about what they perceive as the barriers to employment is certain communities do not see us as an employer because the way we describe stuff, in fact we use our own separate website. Healthcare support workers are under nursing, so a lot of people say, well, I'm not a nurse, so I can't click there. We stick things out and we describe it the way we want it, rather than say, actually, here's a community that've got skills and assets. How do we use those skills and assets? And so I think for me it is almost, we need to fundamentally rethink, how do we recruit, and what do we value in that recruitment process? We make it really hard for our managers as well, because they'll tell you that it takes so we did so at Salford Royal there were 9 HCA adverts out, and when I looked at who'd applied, 6 people had applied for all of them. So that meant they were being shortlisted 9 times. They were going to be called for interview 9 times, but they were only ever going to take one job. So actually, we and I'm not a HR expert, so I don't. This isn't criticism. It's just when you put a different lens on it and think, actually. So I think that from the work that we've done through the most recently around HCAs, that's really what we're thinking about. The other thing is, communities don't like it when you go out with one job because they don't know what HCA is. So actually, when you start talking to people, so we've gone out and done a targeted, let's talk to you about healthcare support workers. I found a dentist, I found a porter, and I found people who want admin, because they just saw the word NHS and came and had a conversation. So there is also something about, we need to almost take 2 steps back. So what we're trying to design is a triangle of recruitment that says, how do you support people, exactly as Karen said, in terms of understanding your population, where have you got pockets within walking distance of your site where you have lower employment rates than in other bits. Go in, talk to the community leaders, talk to people of influence, find out what's going on, partner with the right people, and then have that triangle that starts off with work exposure, pre-employment, into working interview, into job readiness. And that's kind of where we're going with all of this. I don't know if that answers your question, but that's the next big thing in my head. Lisa.
Oh, I love all what you're saying. It's really great to hear. NHS Greater Glasgow and Clyde, we are starting on our kind of community wealth building journey, and we've got a workshop coming up next week about the workforce pillar. And I'd really love to chat with you at some point as well, Donna. It would be really helpful. But I was really interested in the metric side of it, the data side. We're at the stage of looking at the data, but there's so much data there. It's just almost kind of which bits to pull out and how to identify those pockets where we don't recruit from. So again, we'll be looking to get some help on that and support if I could catch your ear at one point.
Yeah, so Claire's helped us initially. So Claire's did a piece of work initially in Oldham, and then I took their methodology and simplified it because they've got bigger brains than me. And I know Neil McAvoy's just moved up to Scotland, so I'm very jealous that you've now got him, because he was a brilliant brain to pick early days. I think the really powerful one is just get it on a map and just put how many people and then what salary by electoral ward, and then link that to the deprivation areas. And we found useless facts. I'll talk about Oldham because it's the one that kind of sticks in my head. So the hospital is right in the middle of population deprivation, which is pretty common. 4 wards around it. 1 ward we employed very little, and the other ward we employed loads. When you looked at protected characteristics, there was no difference. So there was just some. So and then that's when I asked Unlimited Potential, who are a third sector organisation, to go in and speak to that community and say, and we were in Coldhurst. This was the community that the hospital was physically in, and the messages that came back were, we walk past you, but we don't see anybody who looks like us. We don't understand. People like us don't get a job. You never come out to us. You expect us to come to you. And that's really when we started to change some of our pre-employment to say, actually going into the mosque, getting invites into those areas is what's changed. So I used data in its widest sense. So use your numbers to get there and then start talking to people. And if there's one person who you really need to talk to is your FE. Talk to the principals of FE. They know their communities and they know the vocational trainings, and they can bring you, so we're just starting to do a piece of work with our we bring our 4 FEs together because of our and we've got now a formal arrangement, and we're talking about theatres, so theatre staffing, and just they were saying, we'll come into this classroom because we'll have kids who are kind of scientific, and they just helped us think much more about, rather than saying you only can come into theatres via a nursing route, they really helped us think about where else could we go with T-levels and those kind of things. So yeah, I am a bit of a data nerd, but you do have to track something. Sorry, I'm not doing very good at chairing this at all. Michelle, do you want to come in? The public health. Apologies.
So I'm public health in County Durham. I'm relatively new into this role, so there's a couple of observations, a quick observation, a quick question. Our colleagues in the NHS had just put out a flyer, which I thought was really, really good. And it was in terms of, we will come to you, we'll set up, we'll talk to you about jobs, we'll talk to you about, you can be interviewed on the day. I thought it was really good. I thought it was really innovative. But when I read it on the flyer, the second part of it said, we'll interview you, bring 2 forms of ID and a bank account. And I thought, you know, what if you're homeless? What if you don't have a bank account? So initially I started to think, I think there are great things we can do together if we work a bit more closely together, even as simply as 2 weeks before that event, put out loads of publicity to our partners to say, do you even want to pop in and have a chat about, would you be interested in working with us, and try to get across some of these barriers as to why even the word interview, I think, might be a psychologically, it's quite scary for someone if they've never been in work or if they're trying to return to work. So I think there were great things we could do together. The second thing was a question, please. So coming relatively new into this post, I think I came with a bit of an idea of what I thought social value was. I was like bang on in my head with what that was. And then when I've realised I'm speaking to partners, I don't think we're necessarily talking about the same thing. If you look at it from a procurement perspective, my colleagues in procurement are doing amazing stuff, but they're quite clear on what they mean. And I don't think I quite mean the same, because I'm looking at it more from that deprivation and our communities of interest and left behind neighbourhoods, and what can we do there. So I think what we're trying to do in county, early discussions, but trying to get a common understanding of, what do we mean? What do we mean by social value? What do we mean by community wealth building? What do we mean by levelling up? And how do we pull this together? So it's just a quick, it wasn't a quick question, but it really is around how did you go around getting your common understanding of what we mean? And do you think you've got there?
I think because the policy landscape keeps changing, and if in doubt we throw in another phrase that kind of in my mind means the same thing. So I quite simply say, it's, if I'm talking to colleagues within the NCAs, take off the fact that you are a provider for service, and think about your economic and social power and how you use that to tackle health inequalities, of which poverty is the major driver of ill health. So that, to me, that's the space that I land. So whether or not, because it's not, you can you know this, you can improve communities by making rich people richer, because your average goes up. So so when and we're fortunate in all of our localities, we have some high income areas and some areas of absolute poverty, and so that's where you have to be really purposeful, because what I just don't want to do is improve the average by making rich people richer. So which is kind of where the community wealth building for me comes in. So again, it's about being purposeful with your data. So procurement colleagues will say, yeah, well, we set a capital contract and we wanted 45% of people to be employed locally, and I'd go, that's not what I asked. What I want is 45% of people to be employed locally from areas of lower deprivation, and I will get into the, well done, you've got 45% of your population local, show me where. You've got 3 apprenticeships, brilliant, where are they from? Who's training them? Because if all you're doing is training them in your national office and you're not using a local infrastructure organisation, then actually you've just helped 3 kids. That's great, but I want you to help 30, because I wanted you to support a class in the FE college that meant other people. So this is where I've got a Bananarama song in my head, that said, hey, and what you do is it's the way that you do it. That when I sit down with contractors, that's the kind of thing I get into. So show me, what does it look like, what does it feel like, and really how deeply you're penetrating those areas. I don't know if that helps. but I again, you know, I always say I'm a generalist. I'm not a social value expert. Don't ask me about the law. I don't know it. Procurement colleagues do. But that's how you work together. Any other questions or comments, if anyone else wants to share what they're doing, or maybe think about how you could work as a community? Patsy? So Patsy, are you on mute?
I'm not now. We usually go out. I've done some work with the Kickstart, so it's just finished now. We've trained my last cohort last week, but we usually go out to the DWP and help speak to the people there, and we'll ask them who'd be good, who can they put forward. And because that's finished, we went out last week and we had an open morning. So we'd asked anyone to come. We'd help them apply to track. We'd show them what job vacancies we had. We helped them through with any applications that they wanted to apply for. And we do have a really good relationship with our local DWP. We're going out again on Thursday for a job fair. And you know, we talk through any roles we have, and we found that relationship really is a good way forward to help people that want to join the NHS.
Yeah, no, I agree. DWP are our new friends. I think that's what Kickstart helped. And also, just as we started Kickstarts, I got our 4 DWPs together on one of these calls and asked them to raise their hand and talk me through the last time they'd support someone to an NHS job. And I had about 60 DWP advisors on the call. Not a single one had. I just thought, oh my goodness, that's us. And it was almost like it's too complicated. So I'm with you. We need to go and walk in their shoes a bit and use they've got great facilities as well. Some of the gateways that DWP have got are nice facilities to interview in as well.
Yeah, they also helped with, you know, some of the employment checks. So as you said, sometimes the DBS and the employment checks can take a while to get into the NHS, but the DWP helped with quite a bit. They were really supportive, and it worked both ways, because we'd go out and help with any young people that they felt were really good. It was really works as a good relationship.
Yeah. I mean, what I'm, you know, if I rule the world, I'd get schools to teach people about DBS checks, because, you know, we need to be talking to people about having ID is really critical.
Yeah.
And you know, and I stupidly flipped through all our utilities bills, and I haven't got the most unusual surname, but I found 3 bills where my name was spelt wrong. But I've got a passport and a driving license, so I never really checked that. So actually, for some people, your mobile phone bill misspelt your surname is the difference between whether or not you get a job or not. And we've really got to do that in terms of particularly talking to some of our communities where women don't necessarily have their names on things, how we can work with certain communities to say actually that's a barrier, and you know, doing that in an appropriate, sensitive way. Those things I think are really important as well. Anybody else want to come in? Share anything they're doing? Julie, I don't know if you want to add anything, because you've been on some of that journey with us for the last 6 weeks. Anything you want to share?
I think my biggest learn, like you say, was I went to shadow one of the first days at Oldham, and just some of those barriers that came up in interviews, you know, a lot around childcare. So some people had never left, you know, they're in a different country, they'd never left the children before. There was a network of support, but actually trying to get to work and working around some of the hours that we advertise in the NHS. If you're the only parent and you've got to try and take a child to school by bus, then get another bus to work. And, you know, you can't start till 9:30, not 7:30 when some of the shifts. So it's around changing some of those sort of infrastructures as well, and supporting people. How do they find out about childcare before? Because I believe they have to have a role offered before you can get your free hours. And actually, how do you set that up so that apprehension about leaving children for the first time, but wanting to work to give your child a better, you know, heads up for their lifestyle is a big barrier for people. So childcare, you know, travel, working hours and the DBS checks was a major thing for people.
And what
But
we've also,
great day. It was fantastic.
what we also find in the pre-employment, because we have people in kind of cohorts of 10 to 12, is they create peer support. So on that day, there was almost like a baton child minding going on, that they brought, 4 women brought their children to the house that was closest to the hospital, and they all nipped out to do their interviews. And actually, it's how do you then nurture those sharing of childcare before and after, so that before formal childcare could kick in. We're fortunate we've got childcare on the site. But yeah, I think that is starting to come through as an issue, particularly post-pandemic, when a lot of child care, the kind of one-off childminders have gone out of business, and you're left with the big firms who basically offer institution, year set hours. I think that's going to start to become a bigger issue for us. Okay, well, thank you very much. Sophie's got the slide deck. I'm happy if you want to share it. And my contact details are there if anyone wants to have any further conversations.
Yeah. Well, yeah, I'll share the slide deck, and it's also being recorded, so I'll share the link with you once I get it uploaded to our YouTube channel. Thank you all for joining us today.
Thanks very much, everyone.
Thanks, Donna.
Thanks, Donna.